This is Professor Grodman, Psych 245, Abnormal Psychology Review for Exam 1, Fall 20. Let's start with the term abnormality. It denotes some deviation from a statistical or cultural norm. Historically, this is chapter 1, and we're going to emphasize much more chapters 3 and 5. So basically, skipping over chapter 4, touching upon 1 and 2 a few terms, and highlighting 3 and 5. So we're in chapter 1. Historically, mental disorders have not been treated very ethically or effectively based on certainly the mores of today. The asylums of the 16th century in Europe, people literally shackled if they were displaying neurological or psychiatric symptoms that today would be considered clinical, diagnostic, but not dangerous. But in those days, there was a different take on this, certainly. The reform movement of the 18th century saw the development of a more humane treatment of mental disorders. State hospitals were an example of this. Settings in which people were put in which they were removed from cities and ultimately living in these sort of segregated, removed settings without really any treatment. They were just sort of separate from the rest of society. Um, by the 20th century, there were some advances, psychotherapy with psychoanalytic or psychoanalysis, followed by more psychoanalytic therapies and other therapies, particularly the second half of the 20th century. Also, in terms of somatic treatments, the first ones were really not particularly effective, lobotomies and electroconvulsive therapy. By the 1950s, there were medications that were used with some degree of effectiveness for schizophrenia. They were followed by antidepressants and anti anxiety agents. The 1970s, because of the development of new psychotherapies and more effective medical treatments, medication treatments, there was a growing movement that uh, people really could function and do well in the community, and state hospitals and even private hospitals, but especially state institutions were not only not were only not cost effective, they were not efficacious. So people were removed or discharged from these facilities en masse. This movement is referred to as deinstitutionalization. The aftercare was often deficient, but it was a movement that spoke to the need for people to be mainstreamed and the potential in terms of being able to function quite well in the community. Chapter 2, there are a few terms that might even go beyond the chapter, but um, the chapter dealt with different approaches, sort of conceptual approaches to understanding psychopathology. One model, we'll talk about a few, but one that certainly is of importance, probably has been around since the 70s or 80s, 1970s or 80s. Referred to as the diathesis stress model, which speaks to this diathesis or biological vulnerability that probably most of us have in some way, whether it be for substance abuse or depression or anxiety, schizophrenia, or anything that is, you know, um, relevant psychiatrically. But those symptoms don't necessarily activate or fully activate. They need a stressor. So it's the interaction of the diathesis and the stressor that produces the symptomatology. A bit more complex and model which I believe followed diathesis stress is referred to as the multifactorial polygenic threshold model. The multifactorial polygenic threshold model. And this spoke to individual differences in tolerance of psychic pain, psychological pain, and that each of us has a different sort of point in which we start to experience psychiatric symptomatology and psychological dissonance or discomfort. And why are there different threshold levels for each of us? Well, it has to do with our unique learning histories, multiple learning factors, as well as polygenetic factors, multiple genetic factors. And once this threshold is exceeded, you start seeing psychiatric symptoms. Some other points regarding behavior in psychopathology. It's been found that social supports are really important in terms of buffering us from stress and reduce the manifestation of the aforementioned psychiatric symptoms. Attitude also matters. People who are optimistic do better than people who are pessimistic. Well, that's partially a function of already sort of pre-morbid psychiatric state. If you, as one psychiatric state, if you're depressed, you're more likely to be pessimistic than if you're not depressed. But attitude, independent of that, still matters. There are also a couple of types that fall outside in terms of personality, I should say, that fall outside the DSM that are worth mentioning in terms of just looking at how our psychology affects physiology, how our brain and our mental health affects our physical. And examples of this include type A personality. You've heard of a type A, a hard driving, driven person, ambitious, and they don't come in one size fits all. There are different types of type A people. Most of us are not type A, or type B is the opposite. Actually, it's not type Z, but type B, in fact. And type A people, some of them sort of enjoy being type A. They feel very driven, but also in control of their lives, and feel that they enjoy challenges. They don't see them as obstacles, but rather as challenges. Folks like these are no more at risk for health related issues than people who are not type A. But so they're actually referred to as hardy type A's. Non-hardy type A's, though, are more at risk for health problems, specifically heart disease. And they're the types of folks who take on a lot but get easily overwhelmed. So this is type A, non-hardy. The type B person, as just noted, is super relaxed, not a worrier at all, not particularly driven. And this is sort of a wash in terms of health. It's good to be relaxed, but you also want motivation, and they may be lacking in motivation. Type C's are internalizers, particularly internalizers of negative emotions such as anger. And they link this most specifically to stomach cancer, not necessarily to other cancers, but stomach cancer. So that's chapter 2, at least some of the points in chapter 2. Moving on to chapter 3, we're talking about assessment. We're going to highlight this chapter again. And the three-stage model you should certainly be aware of is the assessment, diagnosis, and treatment model, the ADT model, as I refer to it as, a good mnemonic. And in terms of assessment, there are three methods of assessment. Primary is the clinical interview, where you ask questions, you observe behavior. Sometimes psychological tests are used. Intelligence tests or personality tests that look at, a personality test will often look at objective evidence. Excuse me. I have a bit of an allergy. And anyway, projective tests and objective tests. They're both personality tests. Objective gives you, sort of a paper and pencil, true, false, or just, a couple of choices. That's an objective test. You get an actual metric that looks at traits like, if you're extroverted, or if you're, you have paranoia or depression. A very famous personality test is the MMPI. But I'm not going to test you on that, but it's worth mentioning. The Minnesota Multiphasic Personality Inventory. Another type of personality test is called projective, and that is there's a theoretically neutral stimulus in which you look at a card or you look at a drawing, and what you see in that drawing is more not the drawing itself, but your projection of what's going on in your head that you're putting onto that neutral stimulus. Largely, these are not used a lot. First of all, you need specialized training as a psychologist, and the clinical interview is the predominant one. Neurological or medical tests are sometimes used as well, particularly as rule-outs to, maybe someone has headaches and you want to rule out that it's not neurological, or very well may be, and you want to understand the relative influences of the biology and the psychology. So it may not be a part of the actual assessment process. It may be someone has to be or has been evaluated by a physician, but that's worth noting and worth investigating, getting that information. Okay, so what is part of the assessment process? Well, we're getting back to the notion of a clinical interview. And this interview involves observational notations, or just observing behavior on the part of usually an individual, and also questions you're going to ask. Closed questions, how old are you, what is your name, and just open-ended questions, things like, tell me about yourself. You certainly want to establish rapport with someone. Find out why they've come to the center or to your office. The presenting problems and symptoms are really very important. How many, for how long, the severity of these symptoms. You will ask questions about person's thinking. Do you ever have thoughts you can't get out of your head? This is referring to an obsession. You'll make note if they have very odd or distorted thinking that's extreme. That might be a delusion. You probably will ask questions. Do you see things or taste, touch, smell things that other people don't? You're inquiring about hallucinations. You would probably ask about why they've come to the center. If they offer a reasonable answer about getting help, that sounds like they may have some insight. You'll make note or ask questions about decisions they've made. You're assessing judgment. So these are the sorts of things that are noted in your questioning of that person. You will ask also about behaviors that are performed in a sort of a ritualistic manner. These are compulsions. Often they are what follows an obsession. So a person talks about thinking about their hands being dirty, and you ask, do you ever wash them? Yes, I wash them repeatedly. So you'd make note of that, the thinking and the behavioral component, the compulsion. You want to, at some point, particularly in an initial clinical interview, ask about their, you have any thoughts of hurting yourself or anyone else? We're asking about risk of hurting self or others. Non-verbally, you'll want to note about general emotional state, mood. If what they're verbalizing is consistent with what their mood is. So if someone's telling you something sad and laughing, obviously that is cause for some concern, or it's certainly noteworthy. Is there any are there any extremes in movement? Are they agitated? Sometimes this is referred to as psychomotor agitation. Are they slumped over? This is referred to as psychomotor retardation. All of these things are assessed. And you certainly do a significant history. If you note, by the way, that they are reporting symptoms that are both psychiatric and substance abuse related, this is called a dual diagnosis. If they have multiple psychiatric symptoms in different areas like depression and anxiety, this is referred to as comorbidity, and you note all of these things. Now, assessment takes you to some preliminary diagnosis and a treatment plan. And the treatment essentially involves the psychotherapy, the orientation of it, the philosophy of it, and how the person is seen, individual, group, and so on, couple. Here are some examples of orientations. Psychoanalysis was sort of the Freudian way of doing therapy in a very intensive way. Today it's referred to as either insight-oriented or psychoanalytic therapy. There's sort of a facetious reference often to people who are sort of a small subset of folks, and they're called Yavis patients, YAVIS, young, attractive, verbal, intelligent, single. It's a bit of a knock on people who are appropriate for psychoanalytic treatment. That is a very small subgroup. Behavior therapy is another philosophy, or behavioral therapy, either term. The focus here is on changing maladaptive behavior. Cognitive therapy, the emphasis is on changing faulty thinking or distorted thinking. Most clinicians, most psychotherapeutic or psychotherapists consider themselves to be eclectic. They use behavior therapy as a phobia. They'll use psychoanalytic if there's an insight-oriented situation requiring that. The actual evidence is that eclectic doesn't work well as a pure orientation. And the modalities, individual by far is used the most, followed by couple or marital. Family therapy is interesting because it's not only a way of seeing a family, it's a way of conceptualizing them. The notion conceptually with family therapy is that the individual is not the only one with a problem, a child or a parent, usually a child. It's the whole family system, and you have to explore that and work with that. And oftentimes in your treatment plan, you will refer to not only a diagnosis, a depression, and type of depression, the severity of it, how the treatment will work. If it's more severe, you probably put something like individual cognitive therapy, which focuses a lot on changing negative thinking and depression to reduce depressive symptoms. Medication therapy or psychiatric evaluation is recommended. you don't normally, as a non-medical therapist, make specific statements regarding medication, but a referral certainly can be made. So you in your treatment plan, you will combine in writing the modality and the philosophy, and some statement regarding frequency of treatment, and possibly some reference to medication therapy. So let us move on to our first category. We're actually going to talk about three categories of diagnosis: anxiety disorders. We're skipping over chapter 4 and highlighting chapter 5. We have anxiety disorders, trauma related disorders, and obsessive compulsive related disorders, these three categories. Anxiety disorders are actually the number one reason people seek out psychotherapeutic help. Probably the most common anxiety disorder is a simple phobia, sometimes called a specific phobia or phobia. It's an irrational fear of a specific stimulus, something that's not going to hurt you, fear of heights, fear of bridges, tunnels, and so on. The best treatment is exposure therapy, getting the person to do and be exposed to this either gradually or more in a more dramatic fashion all at once. This is referred to as flooding. That's one anxiety disorder. Generalized anxiety disorder speaks to people who worry but are highly functional. There's a lot of what if thinking. Sometimes they have muscle aches and tension, but their main issue is chronic worry. Although they're functional, it still diminishes quality of life. Some combination of probably cognitive therapy or cognitive behavioral therapy, combined cognition and behavioral therapy. Medication may or may not be recommended here. Another anxiety disorder is agoraphobia. Fear, by definition, fear of open spaces. And then there is panic disorder, where people have panic attacks, these terrible, noxious panic attacks, where there's often dizziness, a lot of physiological symptoms, dizziness, nausea, palpitations of the heart, and they may or may not have associated agoraphobia. If they have panic, and as a result they can't leave the house or go very far from the house, or can't leave the house without anyone's help, this is referred to as panic disorder with agoraphobia. If they have panic attacks, yet it doesn't seem to affect them behaviorally besides the symptoms of panic, this is referred to as panic disorder without agoraphobia. Finally, in terms of under the umbrella heading of anxiety disorders, is social anxiety disorder, also referred to as social phobia. And the emphasis here is, or the concern here is that the phobia or fear is specific to social situations. Well, this is broader than a simple or specific phobia. It could be a social situation involving a group of people, or being with one person. Often the exposure would gradually work toward combating that phobia or combating that specific social anxiety. So it's one person, you might encourage them being with four, and then three and two, and work down to the one. Or if it's with a group, start with one, two, and successive approximations all the way up to the goal of getting them to be in a group situation. Okay, let's move on and talk about another category of disorder: trauma-related disorders. And traumas are experiences outside the realm of normal human experience, where the person may feel threatened, or even feel their lives are threatened, or safety, or in a really extreme way that they're being threatened. And if you've had a trauma like a car accident or a victim of crime or something of that sort, and start almost experiencing immediately the symptoms, nightmares, feeling on edge, intrusive thoughts about the event, those sort of symptoms, and experience them within probably days. This is referred to as acute stress disorder. This tends to remit if the person starts to talk about it and try to work through it. Sometimes it doesn't, but it tends to remit pretty quickly. Even more severe version of trauma-related disorder is a pretty famous one called post-traumatic stress disorder. And the trauma here is usually more severe, or as severe, but usually longer in duration. And because of the severity and the chronicity, the person often has difficulty negotiating it psychologically for a while, at least a month. It could go on for years. There's almost no maximum amount of time. And maybe the first symptom is, particularly with war, are nightmares. And so it's a delayed response. And once they start to talk about it, either through individual therapy, a support group, or a combination, there is some degree of desensitization or some degree of processing of this that's important psychologically. So it's not unworkable or it does respond to therapy, but it takes time, and that individual has to determine when they're ready. And with PTSD, especially, the person is not ready initially to take this on, sort of has blocked it out. It's almost an unconscious blocking out of an event in some cases. Other times, it's sort of a more conscious suppression or suppressed. These are more suppressed memories. But until the person is ready, they really can't deal with it until a certain point or a certain amount of time has elapsed, and they feel safer or they feel more ready to take it on. Okay, so we've gone through anxiety disorders and trauma-related disorders. I just wanted to finish off. I know we're going through this quickly, but I don't want you sitting here for an hour or two, or being. I think you could probably go through this and replay it a few times if need be. The last category, subcategory, referred to as obsessive compulsive related disorders. Obsessive compulsive related disorders. And the first disorder is actually obsessive compulsive disorder, where a person has either an obsession, thoughts they can't get out of their head, or compulsions, behaviors performed in response typically to obsessions like checking the stove 20 times or hand washing an excessive number of times or counting things. And actually, based on the DSM, you don't have to have both, one or the other, but they often are a tandem. They're often a pair. The obsession is followed by the behavior. My hands are dirty, that's the obsession. The behavioral response, that's the compulsion. And so they often are linked together. There is also, just as an aside, something called an obsessive compulsive personality disorder. This is where people are very organized to a fault, have difficulties with pleasure, and they're really into orderliness, perfectionism, and it has to do with probably being overly organized or too organized and not at all spontaneous. This is considered a type of disorder which is separate from OCD but similar, and it falls under the heading of a personality disorder, obsessive compulsive personality disorder. Finally, hoarding disorder. And this has become sort of a hot button topic in psychiatry and clinical psychology. This notion of excessive consumerism, excessive acquisition of things, and a real reluctance or resistance to discarding of objects. So you have people who will acquire things, at least initially, in a way that makes sense. I need 2 of these, 3 of these. Then they eventually have 100 of them, and it doesn't sort of factor in. They don't even know where they are. The inventory is lost, and it seems that the objects have more meaning than you ordinarily would think or normally would think, and that this is becoming a more significant problem statistically. I think they say in the book about 2 to 5% or 3 to 5% of the population, I think it's 2 to 5%, have hoarding disorder. And there's often a great deal of resistance to giving up of the item, that there is a lot of psychobiological reinforcement going on in terms of acquisition. It's fun going to the flea market or going to Goodwill or going to the church bazaar or whatever it may be, or going online certainly. But the actual discarding of these objects is hard, very difficult, and this could really impair someone's life. And although there are technically, I don't think the DSM, the levels of this, making strict demarcations, there are different extremes or levels, and this can have a real impact on the individual and certainly the family system. And so the goal here would be more in terms of cognitive therapy or cognitive behavioral therapy, working on, and true of OCD as well, working on changing both thinking and behavior. Certainly with OCD, medication therapy is often in line. Hoarding disorder, possibly in terms of the compulsion, so that it could be certainly medicated. But certainly a behavioral component. By the way, I didn't really talk about meds and trauma-related disorders. Not a major factor. Certainly talk therapy or support group seems to be maybe primary with the trauma-related disorders. So anyway, just finishing off with OCD and hoarding disorder. The both of them have to do with typically with some sort of obsession and compulsion. With hoarding disorder, the obsession to purchase something, and then the behavior, the compulsion. Although it is now, yeah, it's under the heading of OCD, so it does fall under that. So just to know that OCD is your standard, either obsession or compulsion. Hoarding disorder is more specific to the acquisition of objects and the excessive acquisition and the resistance of discarding of the object, and also the sort of thought of I'm going to I'm going to get a bargain today, and for the 100th time you buy the same object, the compulsion, but at some point it starts really working against you. All right, so that brings us to the end of our very brief discussion of chapters, mainly chapters 1, 2, 3, and 5. We skipped over 4, and we emphasized more 3 to 5. If people have questions, they can certainly contact me by phone or email. This tape is being made, this audio tape, late Saturday evening, but I think it should be online. There should be a link to it on Blackboard tomorrow, Sunday or Monday, the latest, and hopefully it will help you in terms of preparing for exam 1.